Okay, good afternoon, everyone, and thank you for joining our weekly COVID-19 webinar. Just a few rules. If you have any questions, please put those in the chat, and we will answer those at the end of the webinar. If you have anything that you want to suggest for upcoming webinars, please let your PBEs know, and we will make sure that we get those incorporated into the next webinar. So our agenda, we are going to have Stuart Mock, our quality director, go over some quality measure documentation refreshers for y'all getting patients in to be seen for AWVs and things like that. We are going to have some human resources updates for some guidelines and some information for when you're having your staff come back into your office by Crescent Beavers, and then some COVID-19 updates that have happened within the last week, also by Crescent Beavers, and then we will have our open forum for any questions that you might have. Okay, take it away, Stuart.
Everyone, so I wanted to take a little bit of time and just go over some of the quality measures, and I know we've talked about updates to the quality program, but just discuss some best practices and things that we can be doing to help that during this time. So as an update, these quality measures continue to be important during the public health emergency. There hasn't been any indications that quality won't be measured for the 2020 year. Really, so far, what the legislation has shown is they will make adjustments towards the benchmarking goals and the MA plan, but then that will change towards based on national averages. Also for the ACO programs, quality scoring will be adjusted with higher of the mean score for the nation versus our actual scores, but that still means we want to try to optimize our score. So the bottom line really is we need to try our best to adjust to this new normal and capture as much quality gap closure during this time. To review, a lot of these measures, and we'll go over a few in the following slides, can be captured in just discussion and documentation during telehealth and virtual visits. If additional actual testing or evaluation is needed, it's still a good time to discuss what that is with the member and get that queued up and ready to go based on how quickly it needs to happen and the urgency around the need. And then it's also a good time to look at alternative options for testing and different routes that might be available. We'll go over some of those in the following slides. So just going through a few of the high frequency measures for breast cancer screening. That's one of the measures that if it's been done, just documentation is enough to close the measure. So obtaining the report is the best option if we're not able to do that, as long as the member is able to give you the date of the screening, even if it's just a month and a year. The results, whether it's just normal versus abnormal, or if there's exclusions such as bilateral mastectomy, those types of things, that's documented, that closes the gap, as long as the date of that screening was within the reporting period. If the screening is due, great idea to give the patient options, and this is a really good time too to push imaging centers as preferred to hospital-based imaging. It's lower cost and there's just a little bit less activity and COVID activity in those areas. Next slide. For colorectal cancer screening, similar to breast cancer screening, if the members had a colonoscopy within the last 10 years, getting the report is best. If not, just the date and type of screening and results will close the measure, as long as the type of screening is within the look-back period. If screenings are due, it is a great time to discuss with members the options of FOBTs or FIT DNA tests, such as Cologuard, that can be done from the patient's home. So if they're due for a colonoscopy, or if they're hesitant to go get one, or not wanting to go out, those kits can be mailed, and the FIT DNA tests are good. We'll close the measure for 3 years. The FOBT will close it for a year. It's a nice non-invasive option for members during this time. Next slide. Quality measure documentation for diabetic screenings. We have the A1Cs. a good time to look at when that last test date was done, if it was out of control or if it's overdue, scheduling them to go in and get labs so we can keep track of that. Nephropathy screening as well. There's various different things that will close that measure and documentation, such as, if they have history of nephropathy, if they're on an ACE or an ARB therapy, but if testing is done, those can either be scheduled at labs. Actually, some labs for both urine microalbumin and hemoglobin A1C, there are some kits that can be sent out to patients' homes that they can do. They can do a blood sample and a urine sample and send those in and get results back if it's needed. And there's significant concerns with going to a testing center. Eye exam, if we can get the report, that's great. If the report isn't available, just the date of the screening and an important documentation piece here to allow your documentation to close the measure is the name of the ophthalmologist or the optometrist that provided the service. So if the patient is able to know who their eye doctor is, that will help close the measure by documentation. Following is a list of screenings that can really pretty easily be done over telephone or virtual visits because they have a little less of a physical component. So fall screenings, depression screenings, render that PHQ-2, so even just those first two questions will complete the requirement for a depression screening. If those are positive, the PHQ-2 is positive, completing the full PHQ-9 could be done. But doing that PHQ-2 over the phone is a good way to address depression, and it won't take quite as much time as going through the full PHQ-9 if it is negative. And it is a really important time to check on the mental health of these members because so many of them are struggling with things. So if positive results are found, make sure that follow-up plans are documented. Tobacco screening, flu shot, discussing if it was received last year, and then prepping the conversation for getting it done this year is really important. We have not only COVID going on, but flu. So getting as many members getting their flu shots this year will be really helpful. And then the Cure for Older Adult screening, the assessing for their ADL, pain, and medicine reviews can all be done over the phone or virtual visits. These are a couple measures that I wanted to go over. So controlling blood pressure, that's one that would be difficult to do over a virtual visit or a telephone call. Member-reported blood pressures won't count to close the measure, but if you do have members that are on RPM, remote patient monitoring, those remote patient monitoring blood pressures will count to close the measure. So if there's any members that you're really working on blood pressure control, but they're not able to get to the office, RPM might be a good option at this time, not only to monitor them, but make sure that get those measures closed. BMI assessment, we need both the weight and the BMI to close the measure, and you can use member-reported height and weight. So if you're able to collect that over the phone and calculate that in your notes, that will close the measure. And then for our commercial contract cervical cancer screening, documentation of the type of screening result will close the measure as well. And the final plug, there's the tip sheet we have up on the website goes through all of these measures and those specific things in documentation that you need to document to close the measures, or the CPT2 codes that will close the measures as well. So if you haven't seen that, you can ask your PBE or reference the website. It's a good reference tool.
Thank you, Stuart. Now we will go to Crescent Beavers to go over some human resources updates.
Thank you, everybody, for attending today. We just wanted to bring to you some good, helpful resources in regards to human resources that our human resources department has put together, of lots of things that offices may be questioning on what we should do and how we should do it. And So we wanted to just kind of do a real high-level overview of things that we need to consider when we're having our employees come back to our offices and our clinics. So phasing in these employees on returning to work, use your seniority or other non-discriminatory factors for selection if possible, determining schedule changes to provide the greatest protection to your workers, creating a plan for the employees in high-risk categories for infections to return to work. Consider allowing them to work from home if they are a non-essential employee or remain on leave until they feel comfortable to return. Determine increased measures to protect them while they are on site to make sure that you have, the appropriate PPE for them if it is needed, or fewer days in the office. Notifying the state unemployment agency of employees that were brought back to work. You need to make sure that those notifications are going out to meet your state requirements and to help save you on your unemployment taxes if you do have employees that are out and filing for unemployment. Determining how to handle employees who are unable or unwilling to return to work. Some employees are still very fearful of returning to work or returning even out into the public world. They have family obligations. They take care of elderly parents or grandparents or other relatives or someone really close to them, and they're not able to work. And then there are those that who wish to remain quarantined for their own personal protection. And then you have those that have had exposure to COVID that must remain under quarantine. Workplace safety. Employers have to ensure that their workplaces are safe as they can be. So develop an exposure and response plan that addresses isolation, containment, and contact tracking of procedures, your stay-at-home requirements, your exposure communication for affected staff, providing the appropriate PPE, mask, gloves, face shields, hand sanitizers, soaps, any of those kinds of things that are needed in the office. Detailed cleaning procedures and procuring of ongoing supplies, making sure that everything is wiped down in between each patient, which we generally do that anyway in a clinical practice, but just being more conscientious of everything that we do in these detailed cleaning procedures. Establishing physical distancing when possible in the workplace. Make sure that you're staggering shifts on lunches and rest breaks, moving workstations to increase separations, and implementing one-way traffic patterns through your workplace if all possible. Employee benefits. Whether employees remained on your practice benefit plans or not, certain notices and actions may be required to stay compliant. And communicating with your insurance providers and providing these changes to your employees should be done as soon as possible. So you need to review all of those contracts that you have with your health plans, any of those kinds of employee benefit plans, your 401k, paid leave. All of those need to be reviewed to make sure that you're staying compliant with those. So ensure that the coverages are staying in place. If they have been furloughed, what rules need to be followed for 401k to in consideration of any breaks in those service issues. And paid leave, review required leave under the Families First Coronavirus Response Act to ensure employees understand the eligibility and requirements to provide them with the policy, and create ways to track and collect the documentation for your credit, tax credit purposes on these. So if you have any questions regarding that, please feel free. We can reach out to our HR department if you have any questions, and see if we can get any further clarification for you on any of those kinds of questions that you have. So we'll go on into our updates and reminders of COVID issues. One of the things that CMS has finally clarified for us, this week was in regards to the telephone visits versus telehealth service visits, and which ones count towards our HCC risk scoring or our RAF score. So they have finally come out and said that they will only accept the following 6 CPTs to count towards a RAF for telemedicine. That's your 99421 and your 99423, which is your online digital E&M services by a physician or other qualified healthcare professional, or your G codes, your G2061 through 63, which is your qualified non-physician healthcare professionals. These codes became effective on January 1, or generally your short online assessments by qualified health professionals to review the patient input in order to determine whether an office visit is warranted. These E-codes fall in line with the E&M of professional assessment conducted via patient portal. And these CPT code sets are for the use of physicians and other healthcare professionals who normally bill E&M services. The telephone audio only visits do not count towards your risk, but are billable for reimbursement. So don't confuse these with your regular E&M codes that you're billing for those patients, those E&M codes that you are billing if you're using another platform like Doxy.me or any other audio visual platform that you're billing those regular 99211s through 215 codes through. Those still count towards your RAF score. It's just the telephone visits that do not count towards the risk score. They have also announced that there has to be a transparency of a cash price for COVID-19 testing. In Section 3202B of the CARES Act, requires providers that provide diagnostic tests for COVID-19 to have a public cash price on their website if they have a website. This would be for your self-pay patients that do not have any means to pay for the testing or the collection of the testing. That price must be established and posted on your practice website. And the CARES Act also grants the Secretary of HHS authority to impose civil monetary penalties if the provider does not comply with this requirement and does not make a corrective plan once it's discovered, and it gets you up to a $300 per day violation if it continues to go on. So this is something that we really need to pay attention to, and if you are providing these collections and sending them off, or if you are actually doing the testing in your office, you have to establish a cash pay price and it be posted on your provider website.
Thank you, Crescent. I don't see any questions in the chat. I do want to remind you that we have received your PPE supply orders, and we are working to get you more information on when those will be available and when pricing and how payment will work and all of those things. We are working on getting all of that ready for you. So just keep a lookout for an update on that from us here pretty shortly. Is there any questions that y'all might have that you want Crescent or Stuart or us to take back to our HR manager about staff coming back into the office and procedures like that? I'll give you a few minutes if you do have any questions. Okay, well, thank you very much for attending our webinar. We will see you next week at our next weekly webinar. So if you have any questions in between now and then, please contact your PBE, and we will see you all next week. Have a great rest of your week.
Thank you, everyone.